PNF was developed in the 1940s and 1950s by Dr. Herman Kabat and Maggie Knott. The founders observed that traditional therapeutic approaches were not sufficient to address the complex movement deficits seen. The founders integrated knowledge of Sherrington's principles of neurophysiology, including reciprocal inhibition and stretch reflex, with functional movement patterns. Reciprocal inhibition is a neurophysiological principle that states during contraction of agonist muscle, the antagonist is relaxed. This allows for smooth, coordinated movement. When a muscle is activated, sensory signals from muscle spindles are sent to the spinal cord. These signals simultaneously excite the agonist muscle and inhibit the antagonist muscle via interneurons in the spinal cord. This principle is used in PNF to facilitate movement and reduce spasticity or stiffness in the antagonist muscle. Reciprocal inhibition is applied in PNF techniques to improve range of motion and coordination. The stretch reflex is an automatic response of a muscle to being stretched. It involves the activation of muscle spindles, which detect changes in muscle length and trigger a reflexive contraction to resist the stretch. When a muscle is stretched, muscle spindles that are sensory receptors within the muscle are activated. Sensory signals are sent to the spinal cord, where they synapse with motor neurons that cause the same muscle to contract. At the same time, the antagonist muscle is inhibited via reciprocal inhibition. In PNF, the stretch reflex is used to facilitate muscle activation. For example, a quick stretch applied to the quadriceps during gait training can facilitate knee extension. These two principles work together to ensure smooth, coordinated movement. For example, during walking, the stretch reflex in the quadriceps facilitates knee extension, while reciprocal inhibition allows the hamstrings to relax. Before, it was mentioned that the founders of PNF integrated knowledge of Sherrington's principles of neurophysiology, including reciprocal inhibition and stretch reflex, with functional movement patterns. I already explained reciprocal inhibition and stretch reflex, but what are functional movement patterns? Functional movement patterns are diagonal and spiral movements that mimic natural everyday activities. These patterns involve multiple joints and muscles working together in a coordinated manner to perform tasks such as reaching, walking, lifting, and throwing. Key characteristics of functional movement patterns are: 1. Functional movement patterns are of diagonal and spiral nature. Functional movement patterns are not straight-line movements. They follow diagonal and spiral pathways that reflect the natural biomechanics of the body. For example, reaching for an object on a high shelf involves a combination of shoulder flexion, abduction, and external rotation. 2. These patterns involve multiple joints and muscle groups working together in a coordinated manner. For example, walking requires coordination of the hips, knees, ankles, and trunk. 3. Functional movement patterns combine stability, including core control with mobility and limb movement, to perform tasks efficiently. For example, lifting a heavy object requires trunk stability while the arms and legs move. 4. These patterns are designed to mimic real-life activities, making them highly relevant for rehabilitation. Here are examples of functional movement patterns. To strengthen pushing an object away from the body, D1 extension pattern is used, which combines shoulder extension, abduction, and internal rotation with elbow extension. To strengthen bringing hand to the opposite shoulder, D1 flexion pattern is used, which combines shoulder flexion, adduction, and external rotation with elbow flexion. To strengthen pulling an object toward the body, D2 extension pattern is used, which combines shoulder extension, adduction, and internal rotation with elbow extension. To strengthen reaching for an object on a high shelf, D2 flexion pattern is used, which combines shoulder flexion, abduction, and external rotation with elbow flexion. To strengthen bringing your foot toward the opposite hip, D1 flexion pattern is used, which combines hip flexion, adduction, and external rotation with knee flexion. To strengthen kicking a ball forward, D1 extension pattern is used, which combines hip extension, abduction, and internal rotation with knee extension. Additionally, scapular patterns, including elevation, depression, and protraction, retraction, are used to improve scapular mobility and stability, as well as to enhance scapular control during functional activities, respectively. Trunk patterns, including flexion, extension, and rotation, are used to improve scapular mobility and stability, as well as to enhance scapular control during functional activities, respectively. The functional movement patterns facilitate muscle activation and coordination, enhance strength, flexibility, and range of motion in a functional context. PNF is based on some principles including 1. Manual contacts, which means therapists' hands provide tactile cues to guide movement. 2. Body position and body mechanics, which means proper alignment and positioning of the therapist and patient. 3. Stretch, which means use of quick stretch to facilitate muscle activation. 4. Manual resistance, which means application of resistance to enhance muscle recruitment. 5. Irradiation, which means spread of muscle activation from stronger to weaker muscles. 6. Traction and approximation, which are techniques to facilitate joint stability or mobility. 7. Timing of movement, which means sequencing of muscle activation for smooth coordinated movement. 8. Patterns of movement, which means PNF patterns are diagonal and spiral movements that mimic functional activities. These patterns involve multiple joints and muscles working together in a coordinated manner. 9. Visual cues, which means the therapist uses visual cues like pointing or demonstrating to guide the patient's movement. Visual feedback helps the patient understand the desired movement pattern. 10. Verbal input, which means clear, concise verbal cues are used to instruct and motivate the patient. For example, the therapist may say, "Push your arm up and out" during an upper extremity pattern. These principles are applied to enhance motor learning, functional movement, improve mobility, strength, and coordination in patients with neurologic deficits.